This is the Fix Your Sciatica podcast.
So let's talk about anxiety and its relationship to pain. The majority of the patients that I see have been dealing with pain for quite some time. And what I have observed, as well as today's expert, is that there is some sort of association or combination of both pain and anxiety, especially when you're dealing with this pain for a long period of time. So rather than have you listeners just listen to my voice the entire time, I thought it would be a great opportunity to interview an actual expert. And this is actually, I've never had a psychiatrist actually on this show. So this is actually a really exciting opportunity. And she's a good friend of mine, and she was really kind enough of sharing her time with us. So today we have Dr. Tracy Foose, who's a psychiatrist, and she's going to tell you all about herself. But Tracy, it's so great to see you this morning, and thank you so much for being a guest on today's episode.
Thank you, Ashley. This is so fun and such an honor to be here.
And the honor is all mine because, one, looking at your work prior to this episode, number one, you're brilliant, which is always so cool to be able to know such intelligent and bright and brilliant people, and especially the work that you do on the anxiety standpoint. Because I know for me as a physical therapist, I can do a large amount of the physical aspects of things, but we know that there is a mental, invisible aspect of how the body and mind works that I can't necessarily address because I don't have the training. And your background as a psychiatrist is particularly helpful because of the fact that, well, one, you've gone through medical school and everything, but I think for starters, let's talk a little bit more about yourself. And then from there, we'll transition just to kind of give the listeners a little bit more of an idea of the difference between, say, a psychiatrist, a clinical psychologist, and I guess the other aspects on the mental health side, if I may.
Yeah, thank you, Ashley. Thanks for the compliments, too. So when you have a psychiatrist, that's someone who went to medical school. So I actually went to medical school with every intention of becoming a surgeon. I was really interested in fixing things, and I started out with surgery and decided that I didn't love the culture of it so much. And I won't get into that today, but there were aspects of the surgical culture that I think I wanted a little bit more sort of humility with the way that we regard problems that we're trying to solve. Not to say all surgeons aren't humble, but there was a sort of cultural element to where I was training that I thought, I don't know if this is exactly where I fit in the whole scope of different medical offerings that you can provide people in the community. So I thought long and hard about what I enjoyed the most. It was actually talking to patients, preparing them for what they were about to go through, asking them what their expectations were, asking them really about the experience of being in their body, and often in their body in pain or in their body scared. And I ended up switching very last minute in medical school to do a residency in psychiatry, which I have loved ever since. I went to UCSF as my first job, my first position out of residency, and did a lot of work there teaching medical students and residents about the neurocircuitry of fear. So fear and behavioral responses to fear. And that was really my niche. Did that for a while, and then decided that I wanted to do a lot more patient care, a lot more clinical work. And so I came out to the community to open a practice that is focused entirely on anxiety and fear-based behaviors. And as a side gig, I still teach at UCSF. So one day a week, I teach the residents.
See, listeners, as I said, absolutely brilliant. Yeah, thank you again for sharing with us with that. So let's take a deep dive into this concept of anxiety and pain. And you provide a very unique perspective with your medical training. I'm coming in from the physical standpoint, right? All the physical without the surgeries and medications. But from your perspective, how would you, from a relationship between, say, chronic pain, like people who've been dealing with pain for long periods of time, and anxiety, do you find that it's it's a chicken or the egg scenario, where it's what came first, or is it a little bit more intertwined with each other?
There's always at the beginning that chicken and egg scenario where you are trying to think about and we're inevitably curious, did pain trigger anxiety, or is this a very anxious person who's been sensitized to pain? Because they can both trigger one another. But at the end of the day, they become a feedback loop. So it stops actually mattering. It becomes somewhat irrelevant which one started it, because anxiety will make pain worse, like I said, by sensitizing the body to pain awareness. And it's more intuitive, I think, to all of us that pain makes us anxious. Being in pain just scares us. It's frightening. So pain obviously makes anxiety worse as well. And then they get into this kind of hurricane loop of building on one another.
Yeah, absolutely. That feedback loop is really interesting, and we'll take a little bit of a deeper dive into that later in this episode. What I find interesting enough is that there are some patients, and I don't have a specific number, but I would say one of the most saddening parts of this pain anxiety experience, or even just pain experience, is that they go to the doctor, whether it be an orthopedist or a general doctor, and they're experiencing all this pain and they have this anxiety. And the doctor says, well, you're just anxious about your pain, but doesn't provide any sort of action step. But then also, I think what's interesting is that one of the questions that I often see in, say, even like the Reddit threads, because I do spend some time there, is they're like, the people who are dealing with pain are asking, how common is it to have both anxiety and chronic pain at the same time? Because is it really just a cop out from the medical community because they don't necessarily have the tools to be able to address it properly? Or is it truly that common and that's why it's such a regularly said thing when patients are dealing with pain for such a long period of time?
Yeah. Yeah, that's a great question, because I equally get frustrated when my patients come to me and they have a chronic pain condition that is linked to an injury, that is linked to something going on in their body, and they have a great deal of anxiety about it because it hurts or it's limiting mobility, and they go to their doctor, who's going to manage the pain, who basically tells them, you got to be less anxious, just feel differently. Which is what we say to people with anxiety all the time. Just don't be anxious, stop being anxious. And they don't really present a follow-through plan. And I would say that anxious people, it's a great question that I'm not sure I can answer, and I'm not sure it's actually been looked at. How many people who suffer from anxiety at baseline, how much more likely are they to suffer from chronic pain if they get an injury? And I think that's actually a great question that I'd love to spend more time delving into. I would expect they are at a somewhat higher risk of developing chronic pain for some of the reasons that we just alluded to about that feedback loop. But I would say that the vast majority of patients who experience chronic pain experience anxiety, because anxiety is our guard dog telling us that something is wrong, that something is a threat. And pain is another guard dog that tells us something is wrong and something is a threat. And sometimes these guard dogs, they get rattled, they're barking at the door, and there's not actually a real threat there, but they're still barking. Both anxiety and pain can do this kind of ongoing signaling to the brain that there's danger after the danger has passed. So I would say that I think a significant majority of patients who are going to be coming in to address chronic pain are going to have anxiety.
And let's talk about a little bit behind the science of like the anxiety and the pain standpoint. Every time I hear or every time I come across scenarios like this, it makes me think about this book called Why Zebras Don't Have Ulcers. I don't know if you've heard about that book, but yeah, it was like often talking about like the chemical processes or the chemical release that happens with fear or with pain, kind of like very similar in makeup, or it's like the same like human response. So yeah, if you can just give us like a little brief overview of what that's like, because you're absolutely right. Like it's that alarm, but we know that alarms are usually elicited by, it's like a stimulus, but then the body releases some sort of hormone or chemical that actually leads to that type of response.
Yeah, and then maintains it. Like cortisol, for one, we know, I think that's sort of out there in the public domain, that people understand that cortisol is something released both in response to pain, in response to threat, in response to anxiety and fear, and it helps perpetuate a chronic vigilant state. It helps maintain a vigilant state. Both pain and anxiety work along some of the same neural pathways in the brain. They both increase activation in the amygdala, which is sort of our deep old, some people call it the lizard brain. That just means we have inherited it, from millions of years ago. Those parts of the brain haven't changed very much, species to species. So there are some very old primal parts of the brain, the amygdala is one of them, that are involved in what we call the limbic system. And that is an area, a part, a circuitry in the brain that perpetuates an emotional state. and it's sort of the relay system, the relay center for managing threat. They're also going to activate areas of the brain in the cortex, sort of the higher thinking layer of the brain, specifically like the anterior cingulate cortex, which is a part of the brain that sort of takes emotional content and then like facts, and data from the world, intellectual content, and integrates them about making a choice. What should we do next? How do we feel about this thing? We feel scared, but we're actually seeing that things are okay. So what do we do? So that's a kind of integration of information area of the brain, and also the medial prefrontal cortex, which is where we're making decisions about what to do next. And that's sort of the executive functioning center of the brain. So we think about all these areas, and all of these areas are equally triggered, activated by both pain and anxiety.
As you were describing that, I'm envisioning a 3D outline of the brain, and every area that you were talking about kind of lights up in regards to as you were describing it. So I thank you so much for sharing that, because I don't think there's a huge opportunity for patients and listeners to have an understanding or even just like a visual or a guide of like how this all works. Because I mean, we look at it, it's like pain is pain, anxiety and anxiousness is anxiousness, and I feel personally that it provides a little bit more comfort to be able to see like how it works a little bit.
Yep.
And I really
I couldn't
appreciate
agree
you
more.
sharing that with us. So thank you so much with that. And so let's talk about sciatica pain itself. So listeners, you're on this podcast because you've been dealing with some form of sciatica pain, and sciatica itself is an irritation of the sciatic nerve. But we've known that the sciatic nerve is one of the longest nerves in the body. And oftentimes people think, or even just like the general community will say, the sciatic nerve begins at your spine and then exits down your leg. But truthfully, the nerve itself actually originates up in our brain, travels down our spinal cord, exits our spine, and then passes through our piriformis, which then forms the sciatic nerve itself. And so there's a lot of different areas in which the nerve can actually be irritated. It can be irritated centrally, whether it be in our spinal cord and also in our brain, but also peripherally, which could be influenced by our muscles themselves. And then also the presentation of pain can be very specific as well, because when it comes to pain or even sensations, our nerves conduct, or our bodies perceive, many different sensations: hot, cold, light, touch, pressure, deep pressure, pinprick, heat. And each one of them will actually give us a little bit of an idea on how intense the nerve is irritated. And in some cases can actually tell us where that nerve is irritated. So my question for you, Tracy, with the aspect of sciatic pain, especially when it comes to like neuropathies and nerve pain, have you noticed any sort of ways in which anxiety might actually uniquely influence nerve type pain, such as stuff like sciatica, especially something that kind of like goes all the way from the top of our head to the tips of our toes?
Yeah. Yeah, and if you think about it as you were describing, just it's real estate. There's it's a really long nerve, so there's a lot of real estate to be impacted by the kind of chemical milieu of the body, also of muscle tension, which I think you had said earlier we might get a chance to talk to about later. I think the other thing about the sciatic nerve in particular is that we have a relationship to it as animals, in the sense that it is a nerve that's giving us a lot of feedback about walking, which is probably one of the most grounding things that we are capable of doing as animals. If we are people who are able to walk, who are born able to walk, who've learned to walk, we just automatically assume that walking is our way to get around in the world, to do what we need to do, also to escape danger. So when you have a nerve that is so crucial for mobility that's impacted, I think not only can anxiety uniquely affect the sciatic nerve, but also the sciatic nerve pain can uniquely trigger anxiety, perhaps exacerbate it more than any other major location for pain.
Absolutely. There's a couple of different disability indexes. The most common that I often see is called the Oswestry Disability Index. And what's really interesting is that if you look at the categories of like most debilitating like orthopedic injuries, you're looking at like, it's interesting. It's like more so knee than hip, but then low back has been actually quite debilitating. But it's like low back with the radiating symptoms can even impact things even more, which then brings up this concept of muscle tension. And as we're talking about muscle tension, I also think about posture and positioning itself, because what I find, especially in the majority of the patients that I work with, in the kindest way possible, oftentimes the injuries that we experience are often self-inflicted, not knowingly, because of the fact that we're either, and it's really, and I say this a lot with the patients that I work with, it's not necessarily the activity that's causing the pain, but how we're doing the activity. And it's usually outside the realm of a traumatic injury where you trip and fall, you get hit by a car or something like that. If it's really you wake up and you have pain, or you just bent over and your back starts to hurt, now your leg starts to hurt, it makes me think about, all right, well, what were the other factors that have led up to this one specific incidence of pain? So when it comes to the concept of both muscle tension and the postures that we're in, when it comes to anxiety, does posture and muscle tension influence anxiety, or does anxiety influence posture and movement tension or muscle tension from your perspective?
Yeah, anxiety really influences muscle tension. In fact, muscle tension is one of the diagnostic criteria of generalized anxiety disorder. So, and oftentimes when we're screening people for generalized anxiety disorder, we'll ask about muscle tension in the upper back, lower back, neck, headaches, which we're thinking of as being a secondary symptom caused by muscle tension in those areas. So, yes, anxiety will we don't know why exactly, but we can conjecture about why that might be. Kind of lock an animal down in place and stimulate a lot of flexion of the muscles in the back, in the neck, a kind of protective stance almost. Of course, this is also the stance we use a lot when we're on the computer, when we're working over the sink or counters. Like a lot of our modern day world, we are hunching, and so we're triggering and exacerbating the tension in some of the muscles that would be triggered or exacerbated in a threat response. And again, there's that kind of signaling back and forth between the body and the brain as to threat and are we safe. And we're getting a lot of muscle tension that can, as you mentioned earlier, impinge on nerves, especially the big, long nerves. There's just a lot of vulnerability to those to get pinched and squeezed by tense muscles that are tense because of anxiety.
Yeah, I see it a lot actually, especially like the desk workers. A lot of my work when it comes to people who are working at a desk the majority of the time is actually trying to get them to open up and stand up. And I think it was a couple
Yeah, I'm
years
trying to
ago.
do that as we're talking.
Yeah, yeah, me too, right? And I've been reading a couple books about how actually our posture can influence how our body feels. And I think it was a TED talk actually talking about how our postures influence some of the hormonal release, where it's like if you're about to get yourself ready for a public speaking gig, rather than like say crouching, like looking at your phone, you assume that power pose, which allows you to really open things up. And
Mm-hmm.
when it comes to tension, from my experience, I often say that tension and tightness is often we'll say a human sensation, a human perspective. And it doesn't necessarily tell us if a muscle is truly in what is called a shortened position. So I want you to think about putting your hands together, that's a shortened position, or in a lengthened position, we call it stretched out. And when it comes to managing pain, especially in the sciatica world, it is our job, or even as physical therapists, is to identify, well, which muscle we have to strengthen the muscles that are weak. But what's really interesting is that the muscles that are weak, it's the muscle is either weak because the muscle is either over shortened or it's overstretched. And the reality is that if you try to strengthen a muscle that's already over shortened, you can actually shorten that muscle up even more and cause more irritation, which means that we have to find out those muscles that are, say, over lengthened, have too much range of motion. But then the same thing goes on the stretching standpoint, where if we're trying to stretch out a muscle, we have to figure out, or stretch out or massage a muscle, we have to determine what is the length relationship of that muscle. Is it in a shortened position? If it's in a shortened position, if things are truly bound up, you can tell because there's some sort of joint restriction. Like you can't move your arm, or you can't move your back in a certain way because a muscle is truly blocking you. And if that's the scenario, it would be really helpful to do stuff like muscle stretches to address that muscle. What I think where stretching becomes problematic is when you're trying to stretch out a muscle that's already pretty stretched out to begin with, and that tension that you're feeling or that tightness that you're feeling is really more of a protective mechanism saying, hey, can you please not stretch me out because that's not what I need at this point. And so it is important, if you are going through a stretching and strengthening exercise program for your pain, to be able to identify, is the muscle that I'm working, is the exercise or the stretch truly designed to either strengthen or lengthen that specific muscle. So I really appreciate you sharing that with us, Tracy, because it in the medical community, like, our jobs are to be able to collect the necessary information, the data, and then create some sort of educated guess. And then from there, we can provide our interventions, and then we consistently reevaluate. And I think one of the challenges, especially in the physical therapy world, is that, especially if you're working in the insurance world, you're kind of just like blowing past like patient after patient. You don't have the opportunity to truly reassess the impact of how it is. And especially in the therapeutic standpoint, we're seeing our patients 1 to 3 times a week. So we should have that opportunity to evaluate. But in some cases, if you're overworked, it gets very easy to just get caught in the motions of doing everything versus, say, is what we're doing actually helpful. And I think, especially in your line of work as well, as you have the opportunity to be able to see your patients and see what those changes are over a span of time. But let's go back to the pain and anxiety standpoint. Let's talk about just some specific behaviors or pattern responses when it comes to anxiety, or even just things that, like, behaviors that people experience with anxiety that can actually irritate or worsen the pain, or, like, it's like the activities or behaviors that just aren't quite helping in this scenario.
Yeah. Well, I can use myself because, as you were talking about knowing whether the muscle was over tight, over shortened, over lengthened, that was really fascinating. I never knew any of that, never thought about injury, muscle injury from that perspective. And, I had a bad fall this winter skiing and seemed to have hurt my shoulder. Didn't know immediately. Sort of kicked in a day or two later. Wow, my shoulder really, really hurts. Maybe it was that fall. I kind of got knocked out, so I didn't remember what I hurt. And what's interesting is that initially, of course, our automatic response to pain as animals is to avoid moving that part of our body. So that's probably the most common anxiety response, is avoidance. That is so primary and primal to our threat response. If something is safe, we approach it. If it's dangerous, we avoid it. So our brain is always trying to filter out the entire world around us in terms of what's safe and what's dangerous, and we'll approach some of that stuff and we'll avoid the dangerous stuff. So initially, my shoulder hurt, so I just avoided moving it. And then what I noticed over a course of weeks after that was, wow, now I really can't move it, even if I want to move it. So then I thought, I got to get to the gym. I got to really push through this and do all the same lifting that I was doing before I hurt my shoulder, because I got to get my strength back. That's why I can't move it, is it's weak. So then I started lifting, and the feedback that my shoulder gave me was, I'm going to get even more immobilized now that you're lifting. It feels sort of good while I was using it, or okay. It would hurt, but I would be able to move it, and then I'd stop and it would sort of seize up, is how it felt when you were talking about what our human experience of what's happening in our muscles is, what the feedback is. So what I learned is, oh my gosh, my 2 threat responses: to avoid moving it and to go back and really push it and demand the same kind of work, kind of stick with the same thing. Neither of those was working as a response to this threat. So what I learned, to your point, was that I have to actually roll out all the muscles that are around my shoulder because they were all tight. And I didn't know until I started really rolling those out with roller bars or with a lacrosse ball, that suddenly that is what helped with both mobility and pain slowly over time. So I would say avoidance. To your question, probably one of the biggest things we want to think about as far as behavioral response to pain is avoidance. Probably also closely related to avoidance is catastrophizing. That's a term we use a lot in treating anxiety disorders, which is where you decide that something that's happened to you is a catastrophe and you try to predict the future, what this means. So my catastrophizing was, I'm lifting weights, I'm doing all the things that I used to be able to do, and instead of getting stronger, I'm getting more immobilized. That means this problem is just going to keep getting worse and worse, and now I'm going to lose mobility of my shoulder and maybe I'll need surgery. So that's the kind of spinning into a catastrophic future.
This episode is brought to you by the Patient Advocate Program. Are you tired of not having support between your rehab sessions? Introducing the Patient Advocate Program, and we're focused on your recovery, and we're offering you 24/7 access to a doctorate of physical therapy. Stop waiting in line to be seen and stop spending hours doing long exercise programs. Imagine being able to get all of your care delivered straight to your phone. Best of all, it's affordable. We believe everyone deserves top-notch relief without breaking the bank. So why wait? Take control of your health today and visit ptpatientadvocate.com and book your free call with our experts.
Yeah, thank you so much for sharing that. So the three main things: avoidance, going back and pushing it really hard just to kind of we'll say grit your teeth and bear it. Back in my OG really hard workout days, in some cases people would say just turn your brain off and go. And then the third category is catastrophizing. And I will say my job as a physical therapist is to be able to help on the physical side kind of go through that process. Ultimately, when people are avoiding a position, it gets very fearful and scary. And so really my job as a physical therapist is to create what I call a safe environment to allow that muscle or that joint or that area to move in a place where two things. One, it doesn't increase your pain, or it actually reduces your pain, or you have no pain. Number three, or you have no pain during that specific activity. And the way that we're able to do that is either changing the load, whether you do it with a weight or not, changing the position, because when you're exercising or moving, you can do it standing, you can do it sitting, you can also do it kneeling and laying down on your side or on your stomach. There's a lot of different ways to address that. When it comes to going and pushing straight through something, we are no longer in a position where it makes sense to address the no pain, no gain scenario. The pain itself is going to give us an opportunity to say, are we getting to our limit? What protective mechanisms do we need to put in place? Now, it's very different. Experiencing actual pain is very different than experiencing the muscle pain and discomfort when you are exercising, and even on the competitive standpoint. And then the third part is catastrophizing. And I really appreciate you sharing your experience, Tracy, with even just how your shoulder was operating. And I know that as physical therapists, it is important for us to recognize these behaviors, but also these feelings that our patients are experiencing. Because if we just completely negate them, we don't want to do that either, because it doesn't make sense to not what I call it. I know this word, but I forget it, but it's not justify, but recognize that it's there. And it is important for us to.
That's the word I
Exactly. It's funny because I've seen so many things about validating people's emotions, and I'm like, I was like, why did I miss that word? But anyway, okay. So let's talk about just kind of how you when if someone were to go to a psychiatrist, at this point where they've been dealing with both pain and anxiety for such a long period of time, where they're thinking, all right, well, it might actually be a good idea to actually start to talk to someone about what I'm experiencing. And I am so pleased that we're in a time now where mental health is starting to take a little bit more over the forefront, because there's a lot of things that are truly out of our control. And again, as a physical therapist, I can't do much, right? And so let's talk a little bit more about some of how you would see it, or when the patient comes in to see you, what are some of the challenges or some of the tools or some of the clues that you're looking for during an appointment that helps you do your job most effectively?
Yeah. I mean, I think what I'm most interested in, sometimes I'm curious what started what, because I do think it helps to know, is this a person who suffered from a lot of anxiety before their chronic pain? Because you can kind of figure out, well, which may have triggered the other. But I think one of the even more important factors that I want to figure out is, how do people feel and think about their pain? And feelings, of course, are fear, discouragement, grief, those kinds of reactions that people can have to pain. And then the thinking piece is what they expect, what their beliefs are. Do they think, this was my fault and now I can't keep doing the activities that I've been able to do, which is a little bit of self-blame and also catastrophizing? Do they think that it's someone else's fault? Are they angry about that? Just sort of getting at the emotional and belief system around experiencing pain. So that's sort of the first chunk that I want to get, because that'll really inform our treatment approach a great deal. The second piece I want to do, because this, I think, to your earlier point, I think this helps everybody, is I want to actually do a little neuroscience. I want to teach them about the interplay between pain and anxiety, because so many people feel validated. So these things share common pathways in the brain. Lots of people have this be a feedback loop. The body is actually designed this way. Okay. And especially when we talk about the body's designed this way to protect us, that right there, what we're doing is we're what's called reappraisal. So we're taking two things that make us feel terrible, pain and anxiety. And instead of saying, hey, these are things that attack us or come for us or want to make our life miserable, we reappraise them as things that are evolutionarily there to protect us. So we take some of the threat out of our threat response. Our body's own threat response can become something that we are actually afraid of. Pain and anxiety are the big examples of threat response factors that we are afraid of. And what we want to retrain people's brain to be afraid of is things like catastrophizing thoughts or avoidance, right? Or even, re-injuring. So maybe doing some of the same things that might have brought it on, some of the same postures, some of the same activities. And what we want them to move toward is actually seeing pain and anxiety as protective feedback, but that they are allowed to say, hey, guard dog, I think the danger has passed, but you're still barking. So to have that kind of control or power or sense of like I'm above the hierarchy, of these feedback systems. So that education piece, that reframe, and that figuring out, what is this person's initial vulnerability state? Did they come to an injury with a lot of pre-existing anxiety? Or is this the first time in their life they've ever really been clobbered with anxiety, and what triggered it was this painful experience?
Yeah, thank you so much for sharing that. And with all of that being said, a thought came to mind is, where do you see the role in regards to, say, social media, all of the free content that is out there, in addition to there's some professionals in the community who will say here's your MRI. Well, your MRI looks like a 90-year-old, but you're 30. How much of a role does the outside factors, like the information that we're getting both from the internet, but then also just how some professionals are phrasing these conditions, how much of an impact does that have on the fear and anxiety and the pain that people are experiencing?
I mean, for me, it would have a huge impact. It's different person to person how much you will absorb from social media, how much sort of you will weigh the input of somebody, either an expert on the internet or an expert who's examining you. But all of us take into account, to some extent, the feedback we're getting from other people. And in particular, when they have that kind of legitimacy of, this is a doctor who knows about this stuff, or this is a trainer who works with this particular type of athlete or injury all the time, right? So people can go out there in the world, easily spread misinformation and freak us all out. And likewise, even people we trust and go to see, I think in the interest sometimes of motivating us toward change, they use fear tactics, right? And they actually feed the catastrophizing kind of voice in our head by telling us things are really terrible, as opposed to focusing more on the, man, that looks like it hurts. I see the thing that initially started this all on the MRI, which is a validating thing to hear. And then here's what we're going to do about it.
Yeah, absolutely. And it's this reminds me of in the comic book series, the Green Lantern, for example. What's interesting is that in the Green Lantern, the lantern is green, or because its powers from green because it's the power of will. There is the other power, which is the power of fear, which is yellow. And in the entire series, they're talking about how, yes, fear is a very powerful tool, but it's a very dangerous tool because it can lead us down that deep spiral rabbit hole of just making things extremely challenging. as compared to the other side, like it's obviously the alternative. So thank you so much for sharing us with that, because yeah, in the world of media, we get so much information bombarded at us left to right, and it is important to be able to take note of that. So let's talk about some of the management side of things. A lot of people who are talking, like, they Google anxiety, they're like, okay, here's like some of this like mindfulness activities and such. In regards to I don't know if you can say this, but what's your favorite mode of like behavioral therapeutics that could help out with anxiety? Like what is the one that you're like, wow, I've seen a lot of research talking about the benefits of this?
It's hard to say. I can tell you what my favorite is because it's kind of my wheelhouse. I like doing it. And then I can tell you where the research is, because there's actually research into a number of different approaches, all of which have evidence behind them for working. And so a lot of it is just what appeals to the patient, what is the particular therapist or psychiatrist's comfort zone. So there are probably three main approaches. I mean, there are more than this, but there are three main approaches where we're thinking about the mind rather than just the brain. We're actually thinking about how do people feel and think, and of course the brain also handles appraising physical sensations. So that's sort of a third aspect of what the brain does. And I'll talk about that a little bit later, where we address physical feedback to the brain and the brain's feedback to our muscles and body. But when we're thinking about feeling and thinking, there are three different approaches that come to mind. The first is the cognitive behavioral approach. The second one is acceptance and commitment therapy. And the last one is a mindfulness-based approach. And these are probably the top three that people study and practice with regard to chronic pain. My favorite, because I use it all the time for fear and anxiety, is the cognitive behavioral approach. And so what that does is it really identifies what you're feeling, allows you to step back and observe those feelings, tells you, you can't change what you feel by just telling yourself, don't feel so afraid of pain, or don't feel so afraid of feeling afraid. You don't have control over what you fear, but what you do have control over is what you think about what you feel. So let's start pulling out some of your beliefs. And that's the cognitive piece. Let's start getting at what you believe to be true about pain, anxiety, yourself. And let's start to rewrite some of those stories. You don't have to let go of the stories that you used to say, like, oh, I'll never be able to walk normally again. But you can just observe them and then add in another belief possibility. Like, maybe I don't know that for sure. Maybe I will be able to walk normally again. And so you start to challenge the brain to open it up a little bit to the possibility of different beliefs. And as soon as you do that, you can then ask a person, all right, and if you believed you could maybe get to walking normally again, how would that influence your behavior? And it's pretty easy for people to say, well, I might feel a little bit like more motivated to do my physical therapy, to do my PT, if I thought it was going to go somewhere, if I thought it was fruitful. So that's the cognitive behavioral approach. The ACT, acceptance and commitment therapy, that's actually about saying, listen, pain sucks, and you have it. You have it. So that's the acceptance piece. It's not like you have to like it. It's just, let's acknowledge that this is really happening. We can't pretend it away. You are in pain. Now, what do you want to commit to? What is the meaning and purpose of your day-to-day existence? What do you want to do despite being a person who carries around this backpack of pain and discomfort? What do you want to keep doing even despite that heavy load? So it's a lot about validating the reality of someone's experience, but also giving them permission to continue to live their life despite this burden. And that also can be really helpful. A lot of people are thinking about their life in terms of, I will only be able to get back to living again when I solve this pain. So they get stuck in that area of trying to solve an unsolvable problem or something that they need help solving. And then the mindfulness-based approach is, again, that kind of stepping back and observing stance. And it's the emphasis in the mindfulness-based approach is that you're actually observing what is happening in your present self, in your body, in your environment, without judgment. And when we think about judgment, what we're talking about is sort of these these meta emotions or metacognitions, like feelings about how we feel, thoughts about how we're thinking, right? And instead, we just want to identify, without saying whether it's good or bad, right or wrong, what am I feeling and thinking about this at this moment? Let me just speak it out loud. And mindfulness-based therapy involves a lot of techniques to calm the body, like progressive muscle relaxation, breathing exercises, things like that. So those are sort of the top three. I actually think a lot of the evidence sits with ACT and with mindfulness-based approaches. So oftentimes I will refer a patient of mine who has chronic pain. I'll say, let's keep working together on your anxiety with my favorite, the CBT approach. But why don't you see somebody who specializes in these other two areas, simultaneously or for a period of time? Because there's a lot of evidence for those techniques. And then I do want to come back to the somatic piece or the body piece too. I don't know if you have a later
Please.
question on that, but
No, yeah, go ahead.
okay. So the last piece is when we're actually thinking about the brain as just at its core, sort of a management team for the body. And when we're aware there is this huge brain body connection, lots of times treatments that focus just on the body, so movement based treatments, will really help with anxiety. So massage, yoga, going to PT, doing some focused work on how the body moves and how that feedback of movement gets back to the brain and then influences some of our pain receptors and experiences and feedback. We call those somatic treatments.
Yeah, I love that. Thank you so much for sharing, because it brings up this, I guess it's a strategy, technique, or tool, and it's really easy to implement, is this concept of what I like to call rhythmic motion. What's really interesting is that, rhythmic motion, repetitive cyclic movements, sitting on a bicycle, sitting on a rowing machine, walking, even using an arm bike. You're having these like cyclical, repetitive things that are in a low stress environment. And what's really interesting is the science behind that. If we look at like people who've had a stroke or even spinal cord injuries, when you put them in a rhythmic motion, it activates they're called CPGs, they're central pattern generators. And what's really interesting is that it gets the body moving, gets blood flowing. But what I find from a neuromuscular standpoint, that can actually decrease some of in people who are experiencing a lot of muscle tone, where the muscle truly is restricted in its gripping. When you're moving in a slow rhythmic motion like that, it actually causes the muscles to start to calm down a little bit. This is actually one of the another reasons why I love stuff like zone 2 training, because you can sit on a bicycle and you can ride for 90 minutes, just like slightly above conversational pace, and it gives your body an opportunity to say, oh, I don't need to grip and I don't need to maintain this posture. Now, it's obviously dependent on the position that you're in. If you're like hunched over on a bike, that's a different story compared to like if you're sitting upright. But the rhythmic motion, I'm so glad you brought up like the importance of movement, because here I am at, as of this recording, my daughter is going to be 11 months and 10 days. And I just been seeing so much content about child rearing, and like as babies get a little bit older, like they start to develop all these emotions, and it's like, well, how do they get their emotions out? And I remember hearing this song, it was kind of like, shake your sillies out, and it's like, okay, great, like we've developed these strategies for children, but for some reason at some point in our development over time, we kind of lose that as adults, and it's something that we should definitely be implementing.
Let me add to
Yeah,
that, because
please.
I think that it's a good time to just remind people that the brain and the body are both plastic. And what we mean by that is they are constantly adjusting in response to our environment and in response to what we ask them to do. So, to your point, yeah, when we're asking the body to do these repetitive movements, we're waking up the body at a cellular level. We're also communicating to the brain at a cellular level. We're reminding it what groups of muscles are designed to do. And we're having those groups of muscles do that motion together in a coordinated way. And that's actually, it's repairing and recovering parts of the brain that may have been injured in a stroke. Or it's correcting parts of the brain that may be sending a signal to those muscle groups, don't move, lock down, protect an injury site. So we're rewiring when we do stuff like that. And to the point about your daughter and her development, there's even so much fascinating literature about how important crawling is and how long we crawl and how kids crawl for things like language development. So this feedback between the body and the brain and how the brain is molding and developing and responding to the world around us and getting ready to be an animal that moves very adeptly through this physical world. That all involves what we call neuroplasticity. But there's also plasticity outside of our neurons in our body's cellular structure. I think that gives people this hope, which is so important, that the body can repair itself. To always remind people the body is always changing, always repairing, but sometimes it needs a nudge in the right direction for how to repair, what health looks like, what we're going for.
The whole human body and mind are amazingly resilient, and that's one of many reasons as to why we as humans are at the top of the food chain, and we're like the only species on this planet that have actually like evolved and developed technologies, right? And so it's really something. It would behoove me, especially with your background, like with you being a psychiatrist and with your as a physician as well, is that there is some sort of medication part.
Yes.
So can you tell us a little bit more about like the role of medication in managing anxiety with that's just often associated with chronic pain?
Yeah. So I think probably the biggest medication classes that we think about with regard to chronic pain are going to work on serotonin. And that is because we know serotonin plays a big role in threat response. It's sort of setting the level, the vigilance, and the sensitivity to threat response. And two of the biggest classes that we've seen work well with chronic pain are the tricyclic antidepressants. And when we say antidepressants, it's funny. Oftentimes people are like, but I'm not depressed. And I'm like, yeah, but serotonin actually plays an even bigger role in threat response than it does in depression. Depression is more complex. So we're often using antidepressants. That's just their name, but they work incredibly well for anxiety. So tricyclic antidepressants will work and reduce not only our fear about pain, but the pain itself, our sensitivity to pain, and also SNRIs. So serotonin and norepinephrine reuptake inhibitors. Some of the best known ones are like duloxetine is probably the one that's marketed the most toward chronic pain, but there are some other SNRIs there that have some possible promise toward managing chronic pain. And then when it comes to neuropathy, interestingly, there's also a medication called gabapentin, which can help not only with nerve pain in particular, but it can also help with anxiety. And these three classes of medications are not addictive. So sometimes people end up on medications like pain medications, opioids, for example, or anxiety medications, the benzodiazepine class, for example, like alprazolam or lorazepam or Klonopin, some of these. The opioid class and the benzodiazepine class, the brain develops tolerance to those, meaning it needs more and more and more to have the same effect over time. And that is because the way that those work in the brain to control pain or to control anxiety, the brain doesn't like it. Anthropomorphize the brain too much, but the brain says, hey, no, I want to feel pain. I want to be aware of feedback. So I'm going to adjust to you giving me an opioid, and you're going to need to give me more and more if you don't want me to feel pain. Likewise with benzodiazepines, the brain is like, I want to stay frosty and vigilant to threats in my environment. So I'm going to adjust, and you're going to need to give me more and more for this to work. So that's how people end up addicted to those classes of medications. So I don't ever use those classes of medications to treat anxiety or pain. I really try to stick toward things that are non-addictive and that are working at a brain level to inhibit our response, but not in a way that the brain knows how to override. It took sort of years of figuring out how the brain reacts to medication for researchers to determine what can we give people to alleviate pain and fear without getting them addicted to those substances.
Thank you so much for sharing that. I think it's yeah, when anyone considers like looking into, working with a professional such as yourself, I think it is a good idea to be able to just see like what are some of those medical interventions that are available just so that people can come in informed. And obviously it's important to be able to discuss it with your professional so then that way you know what's going to be the best for you. Speaking of working with professionals, and we're running out of time. However, I know that you're currently full and you're not taking any new patients. So for the folks who are listening to this episode and are like, okay, I think it might be an opportunity or might be a good time for me to start talking to someone like a psychiatrist to deal with this anxiety and pain loop that I'm dealing with, what are some of the strategies that people can take to find the right psychiatrist for them, or even just how to get in touch with a psychiatrist?
Yeah, I think one of the most valuable things to know in our modern times of telemedicine and using Zoom and other platforms is that you can see somebody anywhere in your state. So, physicians, and I don't know to what extent psychologists and therapists of sort of different disciplines, I think this probably applies to those disciplines as well, but you're licensed state by state. So instead of thinking I have to find someone in my town, you can look throughout the state for somebody who may do what you are looking for. I find one of the best resources to be Psychology Today. So even though it's called Psychology Today, that website, you can filter your search to look for psychiatrists. You can look for psychiatrists who work with chronic pain. You can look for psychiatrists who speak a variety of different languages. You can look for psychiatrists who specialize in fear or anxiety. And so you can really look throughout your whole state for people who may be able to see you just using your computer. And then, of course, I do think going in person often has a little bit of an advantage in the sense that you're in the room. Sometimes you can feel like you leave your burdens in the room and you can come back and pick them up later when you're going to meet with that person again. So there's a kind of balance of convenience and availability with also the balance of it's really nice to be with someone in person. But from the standpoint of just getting started, I would say looking on Psychology Today is a great tool. That's what I use when people are moving and they say, how do I find somebody in New York State? I say, let's look together. Let's see who's out there.
Awesome. What a great tool for people to use. Listeners, I'm going to go ahead and put that link into the show notes as well. Tracy, tell us about some of the projects that you're working on so then that way we will know to keep an eye out for it when it comes out.
Well, as you heard me earlier, describe anxiety as a friend and a guard dog and a protector. That's the way I approach anxiety. So I do a lot of talks in our community, especially at local schools. And I generally put those talks up on my website before I'm going to do them. They're along the vein of understanding anxiety. Anxiety is your superpower. That kind of reframe that I was talking about earlier so that we're not seeing anxiety as a threat. And I'm actually working on a book. Slowly but surely, I'm working on a book that is called Good Ones, which is actually a slightly different angle on anxiety, which is looking at people who are vulnerable to anxiety tend to have three main personality traits. And that is that they are sensitive and responsible and uncertain. And so I'm looking at those traits from a temperament standpoint. Like a lot of us are kind of born with our preset sensitivity, our preset sense of how responsible do we feel for what's happening to us or happening around us, and how certain or uncertain do we feel of what we know, what we're seeing, that kind of thing. And this book is actually examining how those traits tend to be the opposite from the traits we see in psychopathy and narcissism, which are, more the insensitivity, irresponsibility, and being very self-certain. So it's a very long-winded explanation. But yeah, that book, knock on wood, will be coming out in the next few years, and it'll be called Good Ones.
I cannot wait for it to come out. I'm excited. I'm going to for sure get myself a copy.
You'll get a free copy.
Thank you. Thank you. And then we'll get you back on here to talk about the book when it comes out. And that way we can just, continue to spread the word. For the listeners who want to kind of follow the work that you've been doing, what's the best way to keep track of that?
Yeah, I think going to my website, which is drfoos.com, drfoos.com. And you can see I put links to articles that I've written or talks that I've given. And there's just a page a little bit about my approach to anxiety and fear and what they are and the purpose they play in our lives, and thinking about them as things that we can channel for good, for our own good, for the benefit of the world around us. But yeah, we can use this guard dog to good ends.
And there you have it, listeners. I'm going to go ahead and put that information to the show notes. Tracy, Dr. Foose, this was awesome. I knew that you were brilliant to begin with, but I learned a lot during this.
Likewise, I learned a lot today from you.
So I'm so excited for everything, and I appreciate everything that you do. And yeah, thank you again.
Thank you, Ashley. It was so good to be here today.
Thank you so much for tuning in. We hope you got some help from today's podcast. And for more info, check us out at ifixyoursciatica.com. Have a fantastic and pain-free day.